Our dear friend Eduardo Ramacati has asked us several very valuable questions regarding using the Caprini score, so that the purpose of this video is to further discuss these problems.
Hello, Eduardo. So one of the things was, if I was to get away with any Caprini version, the one you would use would be 2013, is that correct?
2013, because it's been validated in orthopedic patients, and it shows a nice clear line which has subsequently been further substantiated that for 9 and below, aspirin works very well for total joints, and if it's 10 and above, a standard anticoagulant is superior.
Okay, so that brings this other idea of the validation of the score within tiers, which kind of surgery we're talking about. So that was nicely presented on that Lovastoff paper you like to quote. I'll put the reference on the bottom. So different thresholds, different actions to take that to a different extreme. So what do you do for, let's say, varicose veins? So is it dismissible risk, or some of them need prophylaxis?
I think some of them need prophylaxis, and we don't know the total answer, and the threshold paper didn't really address that. But what we do know is, based on the studies that were done by Lovastoff, he suggested a score of 7 and above gets prophylaxis, unless the patient gets above 10, and in that case, 30 days of prophylaxis, especially for a history of DVT. Now, the Michigan papers show something very similar. They use 8 and above to give 7 to 10 days of prophylaxis, but then again, 30 days is recommended for people with a very high risk factors, such as a history of family history of venous thrombosis.
So even for varicose veins, 2 tiers, more than 7, more than 10, but the answer is yes, they do deserve prophylaxis, and we have proven really the Caprini score does actually help those individuals. Harder question. So we do agree, and I think we do have great agreement. If you have a post-surgical patient, whatever the surgery, 5 and above, they deserve prophylaxis. You're gonna go for the 7 to 11 days. Patients who are 9 plus, you're gonna go ahead and do the extension based on good data for the 4 weeks and a full month of therapy. 0 to 2, they are so low risk that we're not gonna actually benefit them from anything. But what about those 3 to 4 individuals? So what do you do with those?
I think in most patient groups where the incidence is so low to begin with, giving them anticoagulation doesn't really change that. And although complications are relatively rare, I think that puts